Hello, everyone. Welcome to our CAP Echo session today. We're going to be talking about toxic stress, adverse childhood experiences, and trauma. But before we get started, let's go ahead and do our check-in activity. Let's go to our next slide.
Oh, that's me, huh?
Go ahead and throw into the chat. Just introduce yourself, your name, your organization, the county that you practice in. And May, if you could go ahead and launch our first Zoom poll. So throw into your introductions into the chat, and then let's answer the Zoom poll. For those of you who don't know me yet, I'm Joanne Jung. I'm a general pediatrician. I work here at CAP, helping to oversee and organize a lot of the CMA activities, along with Lauren Schumacher and Mei Lum. And so go ahead and throw your intro into the chat and answer our Zoom poll. This is something relatively new that we're doing, as we're putting a little bit more of a focus on burnout. And this is just an invitation for us just to stop and reflect a moment and check in with ourselves to ask, how are we doing now in the midst of our days and our many responsibilities as in providing pediatric primary care for our patients. Thanks to those who have started to answer. I'll give us all another moment here to answer this burnout poll. And if you wouldn't mind, also typing into the chat, just your name, your organization, your county, and yeah, wonderful. Thank you for doing so. Okay, it looks like fantastic. Thanks for the intros as they're coming in. And May, can we share this poll with everybody who hasn't already been shared with everyone? The results here.
Do you see it?
Yep.
Okay, wonderful. It looks like we are definitely feeling some of the stress here, and we are not alone. And as we're getting started, I just want to welcome us. Why don't we just take a moment, take a couple of deep breaths together, just to help ground ourselves and bring ourselves fully here. Feel free to close your eyes, put your feet on the ground, sit up. If you want to put your hands in your lap, and let's take a few deep breaths together. Starting now. Just pay attention to the flow of the air coming through your nose and out again through your mouth. And then one more time. In. You're ready. Please open your eyes. Here's what we all indicated here. And with that, let's go ahead and move on. Okay. A couple of quick announcements for us today. We will be recording the didactic portion of this talk so that we can post it online later. But we won't be recording the case discussion. If you can, especially for the case discussion, we'd love for your cameras to be on. We know it's lunch, please feel free to eat. But this is kind of like the virtual brown bag lunch, where we're kind of gathering together to share our cases and to learn from each other today. So it'd be great if the cameras could be on. If you're interested in sharing a case, please let me know for our next couple of rounds in April, May, or June. And you don't have to have things figured out. This is really about us putting our heads together and figuring out the cases that have us scratching our heads or wondering what to do next. And of course, calling CAP is always another great way to get advice in the moment. And a reminder that PCPs can contact CAP psychologists also for advice on how to provide just guidance on behavior management and other issues with your families. Next slide, please. Okay. Just a reminder to recognize whose land we're on and to remember the Ramaytush Ohlone peoples who are the original inhabitants, the land that many of us are living and working on today. A few reminders of our disclosures, and there are no relevant financial disclosures for any of those of us who have been planning or give this activity or giving the talk today, but we are supported by federal and state funding as listed here. The next slide, please. With that, I'd like to introduce our speaker for today. We are very lucky to have with us Dr. Eva Ihle, who's a neuroscientist and a board-certified psychiatrist who treats children, adolescents, and adults. She is a health sciences clinical professor here at UCSF. She has served as the interim director of the Inpatient Pediatric Psychiatry Consultation Liaison Service, and she's the associate director of the Child and Adolescent Psychiatry Outpatient Clinics. She currently provides psychiatric consultation to community pediatrics clinics, as well as on the Adult Psychiatry Consultation Liaison Services at the UCSF Parnassus campus, and on the Pediatric Psychiatry Liaison Consultation Service at Benioff Children's Hospital Oakland campus. She holds joint appointments in the Departments of Psychiatry and Behavioral Sciences and also in pediatrics. Dr. Ihle earned a medical degree and doctorate in neurobiology at the University of Chicago through the Medical Scientist Training Program. She completed a general adult psychiatry residency, child and adolescent psychiatry fellowship, and postdoctoral research fellowship, all at UCSF. In her research, she has studied social behaviors in songbirds and a mouse model for autism, as well as the mechanisms of salutogenesis in individuals under stress. With that, happily turn the talk over to Dr. Ihle.
All right, well, thank you very much. It's a pleasure to be invited back. And today we'll be discussing trauma in a way that focuses on issues that are trauma adjacent, such as toxic stress and adverse childhood experiences, or ACEs. And so with this presentation, I'm going to focus on the impact of trauma and adversity as it relates to emotional and physical well-being. And so my objectives for this presentation are that you'll be able to understand the relationship between a number of different issues that are trauma related, such as ACEs, stress responses, intergenerational trauma, and toxic stress. Then to recognize the impact of all of these things, so condensed into this idea of trauma, on the emotional and behavioral regulation of mostly kids, but people in general. And then finally, to identify some culturally sensitive interventions to mitigate the effects of trauma on our vulnerable communities. So just to start with some background information, trauma is prevalent. It's prevalent in childhood and adolescence, and its specific prevalence differs with the type of trauma that we're talking about. Physical illness versus neglect, different types of traumatic experiences will differ in their prevalence. And it's also important to remember that not everyone who's experienced trauma develops a trauma disorder per se. Then even when we suspect that a trauma disorder is affecting the patients that we work with, we also need to think about what else is happening, either what else it could be besides a trauma disorder, or what else is happening in addition to that trauma disorder. And so I've listed some common comorbidities or additional diagnoses to think about on the differential when we're suspecting trauma. And one particular diagnosis that I want to highlight is ADHD. I've included a figure here that I've borrowed from the National Traumatic Stress Network. that shows literally the overlap of symptoms between trauma responses and ADHD. And it's quite a list. And I want to highlight this because very often we have kids who are dealing with stress responses, whose stress responses are not recognized, and instead they are being diagnosed as symptoms of ADHD. And so even if ADHD is comorbid with trauma, if you're only treating the ADHD, you're missing a disorder that does warrant treatment. Likewise, when we're thinking about trauma, we need to think beyond the identified patient, the patient who's sitting in front of us. It's important to also appreciate the impact of intergenerational trauma. And just so that we're all on the same page, we can define intergenerational trauma as the transmission of the sequelae or the consequences of trauma from the caregiver who's been traumatized to their child. And not surprisingly, there are a considerable number of consequences. And we know about these consequences from the decades of research that has been done, determining the evidence that adversity and trauma and stress of one generation can impact the well-being of subsequent generations. We've focused on the psychological well-being. We're beginning to understand that the physiologic well-being of subsequent generations are also impacted. From these studies, we understand that there's a relationship between parental trauma, or what has been termed ghosts in the nursery, and adverse childhood experiences, and that not surprisingly, intergenerational trauma actually can contribute to ACEs as well as toxic stress. It's also important to remember that there are interventions to mitigate the effects of intergenerational trauma. I mentioned ghosts in the nursery. These mitigating interventions are coming to be known by the term angels in the nursery, and we'll talk about those momentarily. And just again to make sure that we're clear on terminology and that this idea of ACEs is established, we know that adverse childhood experiences have a variety of flavors, and that all of these experiences can be considered traumatic. They include things like neglect, all manner of abuse, and even things like exposure to caregivers' psychiatric disorder, and things like threats to bodily integrity. Now, this tends to be thought of as exposure to community violence, which is indeed the case. Working in a medical center, it's also important to recognize that chronic illness can be experienced as such a threat to bodily integrity. So medical illness is starting to be recognized as an adverse childhood experience as well. And all of these ACEs can potentially culminate in what we recognize as traumatic stress. Traumatic stress, in turn, can lead to toxic stress, and we will get to that point momentarily. So when we're talking about stress, what we're really focused on is the maladaptive consequences of stress. And there are different types. There are psychological consequences, and a number of them are listed here. So it can mean emotional changes, such as, increased fear or anger or sadness in older kids, and unfortunately in some young kids as well. It can also mean suicidality. There can be cognitive changes as well, and this is where we get into the overlap with ADHD. So children will have difficulty attending to information, integrating information. They could have poor focus in the classroom and elsewhere. And then there can also be experiences such as dissociation and a sense of foreshortened future. Likewise, there can be behavior changes. For younger kids, we see avoidance. In older kids, we can see addiction. And in all ages, we also can see aggression and dysregulation. And it's really important to highlight this idea of the fight or flight response. Too often, kids who demonstrate aggressive behaviors are interpreted in a negative way. And it's important to highlight that aggression can be considered the fight aspects of fight or flight. All of these changes can represent distress in academic or social functioning, and that this distress in turn prevents or limits appropriate adaptive behavior. And as I mentioned, we're beginning to learn that adversity can have an impact on physical well-being, with a number of different systems being affected. Of course, the nervous system is most obviously affected, but other systems are vulnerable as well. Cardiovascular system, our endocrine system, respiratory and immune systems. We know that ACEs increase the risk of asthma onset in kids. So all of these physiologic consequences are what have been now termed toxic stress. And again, in terms of definitions, I will use the definition that was provided by Nadine Burke-Harris, who was our first Surgeon General of California. This is a quotation taken from her book, The Deepest Well, where she defines toxic stress as a constellation of symptoms in line with what we know happens when there is a prolonged activation of the stress response system without adequate support. I also want to make a counterpoint to this idea of toxic stress. We've been talking about the negative aspects of negative or adverse experiences. I want to highlight the more hopeful aspects as well, and focus a little bit of time and attention on the positive effects of stress. First of all, it's important to highlight the fact that we have a stress reaction or a stress response for a reason. It's very adaptive. It keeps us alive. And this fight or flight or freeze reaction, all of which are highlighted in these animal images, again, are with us for the purpose of supporting survival. Stress can potentially be auspicious. You know, a limited amount of stress in the right circumstances can compel us to learn new things. It can potentially bring about peak performance. And even when the stress is adverse, it can potentially foster post-traumatic growth. So the idea of gaining strength and wisdom from challenging circumstances. And this is what leads to this concept of salutogenesis. So when we think about post-traumatic growth or salutogenesis, bringing about wellness despite trials and tribulations, What we're talking about is the strength and wisdom that can come from successfully coping with crises. So another way to think about it is that negative stressors can potentially produce positive change. And we can actively support salutogenesis, recognizing that psychological well-being is a component of overall wellness. And to quote a former US Surgeon General, David Satcher, there is no health without mental health. And by supporting psychological well-being, we are able to support overall well-being. And we can accomplish this in part by paying attention to the internal world of the child, its outward manifestations, right? Again, looking at aggression as a fight or flight response, as well as its cultural context. And then after we've paid attention to all of these things, we can recognize and manage psychological distress that's caused by exposure to trauma. So that's the theory. Practically, what this means is that with our interventions, we can offer trauma-informed and culturally grounded care. And that care harnesses modifiable resilience factors that can promote these concepts of fortitude and growth. These modifiable resilience factors include things like a person's physiology, their psychology, their educational resources, and overall resourcefulness and help-seeking behaviors. And again, you know, enlisting the support of the angels in the nursery that people have access to. When we're talking about managing psychological distress, what that means is engaging in trauma-focused therapies, a number of which have been developed at San Francisco General Hospital in the Child Trauma Research Program. And then finally, we can also link to other psychosocial interventions that can improve functionality and behavior regulation. So in the last few minutes, I want to focus on these different types of interventions. And it's important to just keep in mind that the nature and the degree of distress or dysfunction influences our choice of treatment approaches. So interventions for the stress response include non-pharmacologic as well as pharmacologic interventions. The non-pharmacologic components are provided in this image. I borrowed this image from the Cal Hope website. This website was developed in part during Nadine Burke-Harris's tenure as the California Surgeon General. And it just highlights the different types of what are called stress busters that people can bring to bear when they're trying to manage stress. There are 6 different areas of focus: balanced nutrition, mindfulness, physical activity, quality sleep, supportive relationships, and mental health care. And when we're talking about things like quality sleep, what that means is focusing on sleep hygiene and encouraging a good bedtime routine. For physical activity, it can mean things like relaxation exercises, like what we engaged in ourselves. Good nutrition, engaging in sports. It's also an area where we can think about culturally sanctioned practices. In the indigenous communities, things like hunting, dancing, cross-country running, those types of activity can be helpful in mitigating stress. The mental health care arena, we can encourage connectedness. So strengthening pre-existing relationships with supportive individuals, those angels in the nursery for people. Also includes spiritual practices and ceremonies, culturally significant ceremonies. And then of course, more traditional things in the realm of psychiatry that include behavior-based therapy. I mentioned pharmacologic interventions. When we're talking about treating the stress response, what that means is using adrenergic agents. The centrally acting agents include clonidine and guanfacine. Both are very, very helpful in treating the stress response, and people who have worked with me will know that my all-time favorite medication is guanfacine. It's pretty remarkable what you can do when you can dial down a person's stress response. It's a very, very effective intervention in terms of a pharmacologic intervention. So I will end with a minute to spare and just highlight a few of the salient points that I hope I've been able to communicate. One is that the interventions that address trauma can be harnessed to promote overall well-being of kids who have been exposed to adversity and trauma, and not just kids, but their family members as well. These interventions are both non-pharmacologic and pharmacologic in nature. Non-pharmacologic interventions that are culturally sensitive can be very effective. And ultimately, all of these interventions can enable children to grow up with a sense of wellness and community.
Thank you so much, Dr. Ihle, for this fantastic talk and for these practical tips of things that we can pass on to our patients, even without a psychiatry or psychology referral. So we very much appreciate that.